Basic Mechanical Ventilation, Part 2. Contents of this presentation will include approaches to providing the mechanical breath, modes in mechanical ventilation, weaning from mechanical ventilation, mechanical ventilator displays, adjusting mechanical ventilator alarms, adjusting settings on a mechanical ventilator, and patient ventilator monitoring. Finally, we'll conclude with 2 case studies illustrating some of the points discussed. Approaches to providing the mechanical breath. There are 2 broad approaches or strategies for providing breathing via a mechanical ventilator. These approaches can be referred to as the control of the breath. Most brands of mechanical ventilators have these options. However, some may have one or the other only. The control of the mechanical breath can be seen as volume control or pressure control. Modes and settings in mechanical ventilation. Each of these controls, pressure and volume, will have their own particular group of ventilator settings, which may be referred to as a mode. The attendant chooses the mode and applies the settings available for that mode. The controls and the modes dictate how the breath is delivered to the patient and how the ventilator interacts with the patient. A particular mode will be chosen based on the patient's requirements. Volume control. In the type of control that is considered volume, the following parameters or settings are applied to the ventilator by the attendant. A tidal volume will be set. A tidal volume is the amount of volume that the patient receives with each breath. A normal tidal volume would be 6 to 7 milliliters per kilogram. Therefore, for an average adult weighing 70 kilograms, a tidal volume of approximately 450 milliliters would be set. Note, too much volume can cause injury to the patient's lungs. Another setting, very important, is the respiratory rate, sometimes referred to as frequency or RR. This is the number of breaths per minute. The respiratory rate is set usually between 12 and 16 breaths per minute. Minute volume. The amount of volume the patient receives in 1 minute. This is not usually a setting, but is derived by multiplying tidal volume by respiratory rate. A normal minute volume for an adult may range between 4 to 6 liters per minute, depending on the size of the patient. An example of this would be if I set a tidal volume of 450 with a respiratory rate of 12, this would provide my patient with a minute volume of 5.4 liters per minute. Other settings include the flow rate, also called a peak flow. This is how fast the breath goes in on inhalation, and therefore how long in seconds this phase will be. Peak flow is typically set between 40 and 60 liters per minute. Inspiratory time. In some ventilators, instead of setting a peak flow, there is an inspiratory time setting, which is another way to set the speed and time of inspiration. In this graphic, we see frequency is 12, the tidal volume is 500, and the peak flow is set at 45 liters per minute. IE ratio, it's the inspiration to expiration ratio, is not typically set on a ventilator, but it is an indirect consequence of the inspiratory time and the respiratory rate. The attendant may note the IE ratio in the monitored data on the ventilator. A normal IE ratio for an adult would be between 1 to 2 to 1 to 4, meaning that expiratory time, the second number, is always longer than inspiratory time. Note, in volume control modes, the pressure that develops in the patient's lungs on each breath will vary with each breath. This is dependent on many factors. Other settings for volume control ventilation include plateau or pause. This setting allows a pause in seconds at the end of inspiration and before exhalation begins. This option is not often used. Pattern for flow rate or pattern for the peak flow. This setting allows the attendant to change the shape of the inspiratory flow pattern. There are usually two options. One is called a square, meaning inspiration begins, reaches the set peak flow, then stays there until exhalation begins. Another option is called ramp or slope. In this option, the rise to the set flow rate is fast, and then the flow rate or the speed slows down until the end of inspiration. Here we can see the square and the ramp. So the example here is we have set a flow rate of 45 liters per minute, and it remains at this speed from the beginning to the end of the breath. In the ramp, the speed begins at 45 liters per minute and slows down to the end of inspiration. Slower, slower, slower until the end of inspiration. So inspiration for the square is shorter than inspiration using a ramp. Volume control has, here we can see our plateau, or sometimes it's called pause. In this example, it's called T plateau. And here we can also see the ramp, the pattern, which you could change from square to ramp. Note, flow rate pattern options are only available in volume control. Pressure control. In the type of control that is considered pressure, the following settings are applied to the ventilator by the attendant. Pressure level. This is the amount of pressure in centimeters of water that will be provided on each breath. It will indirectly determine the amount of tidal volume that is delivered to the patient. Tidal volume is not set directly in this control. It is important to set a pressure level and monitor the amount of volume that is generated. This is usually seen on the display on the ventilator screen. Note, too much pressure can cause injury to the patient's lungs. Here we can see, in the example here, the pressure level set. It's called on this particular machine P-insp. That's the pressure level. And over here, we can see the monitored tidal volume in milliliters. So in this example, a P-insp, or a pressure level of 23 centimeters of water, generates a tidal volume of 0.450 liters, or commonly referred to in milliliters as 450. If I increased the pressure level, the resultant tidal volume likely would rise, and if I decrease the pressure level, the tidal volume would likely fall. There are many other factors that impact the amount of volume that's generated on each breath. and therefore the tidal volume does vary breath by breath. Two other important settings in some pressure control modes are inspiratory time. This is the length of inspiration in seconds. It's usually set between 0.75 and 1 second for adults. Respiratory rate, just as it was set in volume control, is the number of breaths per minute. The rate is usually set between 12 and 14 or 12 and 16 breaths per minute for adults. The I ratio, again, is not directly set, but will be determined by inspiratory time and respiratory rate. The monitored range could be between 1 to 2 to 1 to 4. And here we can see basic parameters set or settings set for pressure control. So here it says PC above PEEP, which is your pressure level. It's set at 25. And we have a respiratory rate of 12. We have an inspiratory time set at 0.90. Common settings for both modes in both controls. Trigger. The respiratory rate set by the attendant provides the number of breaths per minute that will be initiated by the ventilator. However, in all modes, the patient may trigger or begin the breath if they have a desire to do so in addition to the set rate. They would need to make a sufficient inspiratory effort in order to start a new breath. The attendant will set a trigger level, which will dictate how strong an effort the patient must make to begin the breath. This trigger level may be set in centimeters of water and usually set around 2 centimeters of water below the pressure registered during expiration. The trigger level may also be set in liters per minute, usually set at 2 liters per minute. Therefore, if the patient were making an inspiratory effort, the total number of breaths per minute could be higher than what the attendant set as a respiratory rate on the ventilator. Note, if the trigger level is set at a level requiring too much patient effort, the breath cannot be triggered. If the level is set too easy, the ventilator may start a breath without any effort required. This is called auto-triggering. Continuing with triggering. Here we have a graphical representation of inspiration and expiration. The peak inspiratory pressure occurs at the end of a full inspiration, and the baseline is seen during exhalation. We can see that here. The image on the left demonstrates that the breath began by the set rate on the ventilator. There was no patient effort. Trigger, we can see the baseline is there. So the patient did not make an effort. The image on the right demonstrates that the patient made an effort as indicated by a dip from the baseline and a breath delivered for this effort. And we can see that the patient made an effort and the dip is seen here. Another very common setting to all modes is something called PEEP. Positive end expiratory pressure. Instead of allowing all of the air in the lungs to be fully exhaled, a small amount of pressure is sometimes purposely left in the lungs. PEEP is an amount of pressure that is left in the lungs during expiration. The pressure helps to keep the lungs open, preventing them from collapse during the expiratory phase. This helps the oxygen get into the blood via the lungs. As we can see by this graphical analysis on the left, inspiration takes place on the left-hand side of this graph, and expiration begins from the peak down. We have reached a peak pressure of 20 centimeters of water, and the expiration is 0. It returns to a 0 baseline. In the diagram on the right, we have added PEEP to the system. So instead of going back down to a 0 baseline, the pressure in the system during exhalation remains at 5. A PEEP of 5 centimeters of water would be considered a low PEEP setting. A PEEP of 20 centimeters would be considered very high. FiO2 is common in all modes. It is the fraction of inspired oxygen. This setting controls the amount of oxygen in the breathing mixture going to the patient from the ventilator. The air around us contains 21% oxygen. However, patients on a ventilator often need considerable greater amounts of oxygen than this. And here we can see the oxygen FiO2 setting. Here it's set at 40%. Other settings, the PEEP of 6. The pressure level here is set at 24, the inspiratory time is set at 0.9, and the respiratory rate in this example is set at 20. Here is a review of pressure control and volume control and the settings that need to be set for each. Make sure you compare the two. In pressure control, the attendant sets pressure level, respiratory rate, inspiratory time, FiO2, a PEEP, and trigger. In volume control, the attendant sets tidal volume, respiratory rate, peak flow, usually, sometimes inspiratory time, FiO2, PEEP, and trigger. What we can note is that in pressure control, the pressure is set, the tidal volume varies, and in volume control, the tidal volume is set and constant every breath, but the peak pressure will vary. Pressure-controlled modes deliver a fixed pressure at variable volume, and volume control modes deliver a fixed volume at a variable pressure. Talking now about the modes. Within each control, volume and pressure, there are many kinds of modes available on different brands of mechanical ventilators. Certain modes will be applicable to certain kinds of patient illnesses and clinical situations. A mode that is very common is called assist control, abbreviated AC. It has other names as well, could be referred to as controlled mandatory ventilation, CMV. This mode is used when a patient cannot do much or any of their breathing on their own. This might occur when a patient is very ill, injured, undergoing surgery, or otherwise cannot breathe by themselves. This would imply that they are unable to bring enough oxygen into their bodies or to remove enough carbon dioxide by themselves without the help of a breathing machine, the mechanical ventilator. This mode is often considered a full support mode. The assist control mode is available in pressure control and in volume control. Here we have an example of assist control in pressure control. Again, FiO2, your pressure level setting, the TI, the respiratory rate, and the PEEP. In volume control, the settings here's an example of some settings. We have the rate, which is set at 24. We have a tidal volume, which is set at 500. We have a peak flow set at 75 liters per minute. We have the trigger is set at 2 centimeters of water. We have the oxygen set at 45%, and we have a PEEP of 5. Some more modern ventilators have what could be referred to as an automatic pressure control mode. In the pressure control mode described previously, the attendant will monitor the expired tidal volume and, if necessary, will adjust the pressure level to generate the desired volume. In the automatic modes, known by many names, including PRVC, VC+, and others, the attendant sets a target tidal volume, and the machine, the ventilator, automatically increases and decreases the pressure level to obtain that volume. Another very common mode, it's in the pressure control strategy, is something called pressure support ventilation. It can be called a spontaneous mode. In volume control approaches, there's only one mode, assist control. This is a full support mode, and it allows the patient to trigger additional breaths if they wish to do so. In pressure control approaches where a pressure level is set and the generated tidal volume provided to the patient varies, there are two basic modes. One we've already talked about, assist control, and another mode called pressure support ventilation, commonly referred to as PSV. This is a common mode, again, commonly referred to as a spontaneous mode. In pressure support ventilation, PSV, there are fewer settings to apply than in assist control, and the patient has greater control over his own breathing requirements. In particular, a respiratory rate is not set, and the patient determines and triggers all breaths they are to receive. The patient must be able to make some inspiratory effort on their own to be placed in this mode. PSV is considered a partial support mode. It is a mode that can be used when it is time to withdraw or gradually remove the patient from the assistance of the mechanical ventilator. This is termed weaning from the ventilator. Note, an assist control mode cannot be used to wean a patient from a ventilator. The following parameters or settings are applied to the ventilator by the attendant. The pressure level. Again, this is the amount of pressure in centimeters of water the patient will receive on each breath. This is the same pressure parameter that is set in pressure control assist control. It indirectly determines the amount of tidal volume that is delivered to the patient. As in pressure control assist control, tidal volume is not directly set, and therefore it is important to monitor the amount of volume that is generated on each breath. The terminology for this setting is not the same on every brand of ventilator. It may be referred to as P support, P insp, among many other names. In this case, it's called P support, and in this case, it's called P insp. Other important settings in pressure support ventilation are something called the expiratory trigger sensitivity. It goes by many names: E-sense, flow trigger, inspiratory cycle off, PSV cycle, flow cycle, many names. This important setting is only available in pressure support ventilation. It controls the length of inspiration, similar to peak flow and inspiratory time settings in assist control modes. The attendant will set a percentage of the patient's peak inspiratory flow that will end the breath. Inspiration is terminated when the patient's inspiratory flow has decreased to this specific flow. 25% of the patient's peak flow is the usual setting for this parameter. And here we can see the patient's peak inspiratory flow. Expiration is on the bottom. And we can see after that, the flow starts to slow down. And when it's reached 25% of the peak inspiratory flow, inspiration ends. Here we have an example of what's called, in this particular model, E-sense, set at 25%. For the most part, this is the default setting. Other important settings in pressure support are the trigger. Obviously, we have to have trigger in all modes. Absolutely essential. The attendant will set a trigger level, which will dictate how strong an effort the patient must make to begin the breath. This trigger level may be set in centimeters of water, usually set around 2 centimeters of water below the pressure registered during expiration. The trigger level may also be set in liters per minute, usually set at 2 liters per minute. PEEP. Again, we are going to use PEEP in a pressure support breath. It is the amount of pressure left in the lungs during expiration in order to prevent the lungs from collapsing during the expiratory phase, and the usual setting for PEEP is around 5. FiO2 would have to be set, and this setting controls the amount of inspired oxygen in the breathing mixture. Most likely it will be set above 21%. So in this example, we can see the trigger. It's a flow trigger. It's set at 2.4 liters per minute. We've got our pressure level. It's set at 10 centimeters of water. We've got the expiratory trigger sensitivity, which is set at 25%. We have the FiO2 set at 40% with a PEEP of 3. So these would be the only settings required for pressure support ventilation. Weaning from mechanical ventilation. When the condition of the patient improves, there are several methods for weaning or removing the patient from the ventilator. One method is to alternate time on the ventilator with time off. And the time off will always be supplemented with oxygen. And the other method is to slowly reduce the amount of pressure or pressure support the ventilator provides to the patient using the mode pressure support ventilation. As the patient's strength improves, they will be able to generate more force to breathe, and the ventilator can be set to do less. To provide less support, the attendant will reduce the pressure level in a gradual fashion using the pressure support ventilation mode. During this weaning phase, the patient will need to be monitored closely for signs of fatigue, such as obvious breathing distress, increased respiratory rate, increased blood pressure, increased heart rate, as well as low oxygen levels. Note, if fatigue occurs, the patient's support, the pressure level, may need to be increased until the patient is once again comfortable, or the mode may need to be changed back to assist control. Weaning using pressure support ventilation. Once the level of support is reduced successfully, usually to a pressure support level of 6 centimeters of water or less, a decision will be made to remove the patient from the ventilator. If the connection to the ventilator is made via a mask, it is simply removed. If the connection to the ventilator is made via a breathing tube, an endotracheal tube, the tube is removed. This is called extubation. If the connection to the ventilator is made via a tube in their throat, tracheostomy tube, the tube will be removed. This is called decannulation. Full breathing support assists control. The patient then moves to a partial breathing support, pressure support ventilation, and finally, the patient does not require any support at all. The mask, the endotracheal tube, or the tracheostomy tube is removed. Review controls and modes. There's a control of the breath, and there's two basic approaches to the control of the mechanical breath. One is called volume control, And in volume control, there really is only one mode called assist control, volume control. This is used when full support is required. In pressure control, there are two basic modes. One is also an assist control mode, pressure control, and this is used when full support is required. The other mode is called pressure support ventilation. This is used when partial support is required or for weaning. This slide shows customary settings, and these settings would be suitable for an adult patient. And this table shows the three modes, two controls, with some examples of settings or ranges of settings in each. Note that in all cases, mechanical ventilator settings must be individualized to the patient's condition and clinical disorder. So here we can see on the left-hand side the settings. We have the three different modes, two in pressure control. We've got pressure control, assist control, pressure support ventilation, and volume control, assist control. And it's very clear to see what parameters or settings are set or not set for the particular modes. So in pressure control, assist control, average kind of pressure setting would be maybe 15 to 20 centimeters of water. Tidal volume is not set, peak flow is not set. An inspiratory time of between 0.75 and 1 second is within normal limits. A respiratory rate between 12 and 16 is within normal limits. An expiratory trigger sensitivity is not set in this mode. A trigger level must be set either 2 centimeters of water or 2 liters per minute. A PEEP regular setting or normal setting, if you want, would be 5 centimeters of water, and the FiO2 would be somewhere above 21%, depending on what the patient requires. In volume control, assist control, we know that we do not set a pressure level. Instead, we set a tidal volume, and the normal amount of tidal volume is between 6 and 7 mils per kilogram. For a 70 kilogram person, we would set around 450 mils. The peak flow is anywhere between 40 and 60 liters per minute. Some ventilators, instead of peak flow, have a setting for inspiratory time. There's a rate to be set between 12 and 16 breaths per minute. There is no expiratory trigger sensitivity. The trigger between 2 centimeters of water, 2 liters per minute. The PEEP of 5 would be within normal limits, and the FiO2 somewhere above 21%. So now we come to pressure support ventilation, and just by looking at this column, we can see there's not as many settings to set for this mode. So we will set a pressure level. I just picked 8 centimeters of water as a 8 to 10, 12 type of normal pressure level. I just picked 8. We do not set a tidal volume. We do not set a peak flow. We do not set an inspiratory time. We do not set a respiratory rate. We do set an expiratory trigger sensitivity. We have to set a trigger, 2 centimeters of water or 2 liters per minute. We will set PEEP, and we will set an FiO2. So this gives you an overview of the 3 different modes, 2 controls, and what's set and what is not set. Ventilator will display a number of parameters, and we'll cover a couple of them here. Parameters such as pressure, tidal volume, minute volume, respiratory rate, among others. Here is a photo of our image of a ventilator with, on the left-hand side, we've got the monitor data. On the right-hand side, we've got the controls that were set by the attendant. So measurements taken by the ventilator can occur as the breath leaves the ventilator, and they can be measured as they return to the ventilator, as seen in most brands of ventilators. readings are going to include pressure, very important. So it's going to record the highest pressure, called generally PIP or P peak, and the lowest pressure, which is usually the PEEP, or if you're not using PEEP, it would be 0. The volume is very important, tidal volume, inspiration, tidal volume on expiration, as well as minute volume. And as well, this could be on inspiration and on expiration. Respiratory rate will be monitored, and this is always the total rate. It would include the rate that is set on the ventilator as well as the rate that's triggered by the patient. IE ratio may be monitored, inspiratory time may be monitored as well. So here in this example, we can see PIP, it's called P peak on this machine. The exhaled minute volume, it's 5.9 liters per minute. The exhaled tidal volume is 250. The respiratory rate is 22 breaths per minute, and that would be total rate. The mode and the settings, this is a pressure support mode, a pressure level of 10, a PEEP of 5, and a FiO2 of 21. It is important that the attendant observe these monitored readings to ensure that the patient is receiving adequate breaths. Adjusting mechanical ventilator alarms. As a life support system, it is imperative that ventilators have built-in alarms to safeguard the patient. These alarms ensure that should the ventilator exceed or drop below a certain alarm limit, a buzzer will sound to signal the attendant. The alarm usually indicates a change in the patient's condition. The ventilator will monitor many aspects of the mechanical breath, as we just stated in the previous slide, such as pressure, tidal volume, minute volume, respiratory rate, among others. Each of these parameters will have an associated alarm setting that can be adjusted by the attendant. Adjusting mechanical ventilator alarms. Alarms are extremely important, as previously discussed. This is a life support machine, and the patient has to be safeguarded at all times. In this table, there are approximate settings for the various alarms that will occur on most ventilators. If there is a low pressure alarm, it's generally set 5 to 10 centimeters of water below the observed PIP, or peak inspiratory pressure. The high pressure alarm is generally set 10 to 20 centimeters of water above the observed peak inspiratory pressure. One thing to note, when this alarm is activated, inspiration is ended. If there is a low PEEP alarm, it's set usually 2 to 5 centimeters of water below the set PEEP. If there's a high rate alarm, usually 10 breaths per minute above the observed total respiratory rate, and a low exhaled minute volume, 10 to 15% of the observed total minute volume, or approximately 2 liters. A high exhaled minute volume alarm is around 10 to 15% of the observed total minute volume, or around 2 liters, greater than the observed minute volume. A high exhaled tidal volume is generally set around 200 milliliters, greater than the expired tidal volume, and a low exhaled tidal volume might be set 200 mils less than the expired tidal volume. To set an alarm limit, the attendant must observe the monitor values or set parameters and then set the alarm limits accordingly. There are specific alarms for pressure support ventilation. In the mode pressure support ventilation, respiratory rate is not set, and the patient must trigger or begin all breaths. It is important, therefore, for the attendant to be notified should the patient stop making any effort. This is called apnea. If this occurs, no breaths are given by the ventilator. An apnea, again meaning no breathing, alarm, sets a maximum time interval between when the patient stops making an effort and when the alarm is activated. The interval for adults is usually 15 to 20 seconds, and it is set at that. In many ventilators, once this condition occurs, the mode will automatically switch to a full support mode, usually pressure control, assist control, with a set pressure level and a set respiratory rate. And here's a table that shows apnea settings of 20 seconds is normal for adults, and apnea ventilation, depending on the patient's condition, 12 to 15 centimeters of water, an inspiratory time of 0.75 to 1, rate between 12 and 14 or even 16 per minute, depending on the patient. So now the question is what to do if the ventilator alarm is activated. It is important for the attendant to focus on the patient first and to decide whether the patient is in danger. And at this point, the alarm could be silenced. There is always a silence button or a silence that can be done for these ringing alarms, or for the majority of them can be silenced. Do not move from the ventilator, and do not reset it, but the alarms can be silenced at this point. Address the alarm situation second. So now's the time to decide what alarm was ringing and why it's ringing. Very often it's not that easy to find out and to come to a conclusion exactly what the problem is. If the patient is receiving inadequate ventilation for whatever reason, they must be bagged using a manual resuscitator with a flow of oxygen. And here you can see the attendant is bagging, has removed the patient from the ventilator and is bagging with a manual bag, pushing air into the patient's lungs. And there is a flow of oxygen coming out the end of that bag. And if one cannot determine what the problem is, then this is what has to be done. It is possible the reason that the alarm has been activated is because it was not set correctly by the attendant. So this is common that this happens. Common causes of alarm activation and possible solutions. A high pressure alarm can be caused by many things. Blockage in the breathing tube, and in this case, the breathing tube may need to be cleaned, or it's called suctioned. Constriction of the air passages in the lung is another reason why the high pressure alarm may ring. The patient may need medication to relax the airways of the lungs. The patient's biting on endotracheal tube, the breathing tube. In this case, the patient may be agitated and may need to be given a calming medication. The patient is agitated, coughing, gagging, or trying to talk. Again, try to explain to the patient what is happening, and the patient may need to be given a calming medication. If the low pressure alarm rings, a possible cause could be that the ventilator circuit is disconnected. It's important to check the circuit for disconnection, and the patient may need to be bagged with a manual resuscitator if the source is not found. It could be possible that the breathing tube is displaced out of the trachea. Examine the breathing tube carefully. Listen to both sides of the lungs using a stethoscope, if possible, for air entering the lungs. If the tube is out of the trachea, it will need to be replaced. A low exhaled tidal volume. When this alarm rings, it is possible again that the ventilator circuit is disconnected. Check for circuit disconnection, and again, if the source is not found, the patient may need to be bagged with a manual resuscitator. Again, the breathing tube may be displaced out of the trachea. Examine the breathing tube carefully. Listen to both sides of the lungs using a stethoscope if possible for air entering both lungs. If the tube is out of the trachea, it will need to be replaced. There could be as well a leak in the balloon of the breathing tube. Listen for sounds of air escaping during inspiration. Add a few cc's or milliliters of air via a syringe to the balloon until escaping air stops. In the pressure support mode, it could mean a low exhaled tidal volume alarm could mean that the patient is tired and not able to generate sufficient strength to breathe. It could mean that weaning during pressure support may be failing. The solution would be to provide the patient with a higher pressure level and support, or perhaps change the mode. If a low exhaled tidal volume occurs and the high pressure alarm has sounded, it is meaning that the inspiration has been prematurely ended. It means that the set tidal volume will not be delivered. This occurs primarily in volume control. Investigate the reason for the high pressure alarm as a solution. The high respiratory rate alarm may ring if the patient is anxious. You would need to communicate with the patient, calm the patient, and perhaps provide a calming medication for him. A high rate can occur as well if there's inadequate support or fatigue. Again, provide more ventilation support, and it could be an indication that weaning is failing. Low oxygen levels may also cause a high respiratory rate, and the patient may need to have increased oxygen level in the breathing mixture. High carbon dioxide level reading may also be a cause of a high respiratory rate. The patient may therefore need increased support from the ventilator, and the attendant would increase the minute volume by increasing the set respiratory rate or by increasing the pressure level. A high exhaled tidal volume. In any pressure control mode, a high exhaled tidal volume alarm could be a signal that actually the patient is improving. Solution might be that the pressure level is reduced. It's possible the patient does not need as much. High exhaled tidal volume can also be a sign of anxiety or shortness of breath. And again, investigate for the reasons for the anxiety or shortness of breath. And an apnea alarm will occur in the pressure support ventilation mode, and it means the patient is no longer making inspiratory efforts or is breathing slowly with pauses. Investigate the reason for the periods of no breathing, and possibly and would be required to change the mode to a full support mode, an assist control mode. Patient ventilator monitoring. A patient on a mechanical ventilator will need to be assessed on a regular basis, likely every 2 to 3 hours. This is necessary in order to verify the proper functioning of the ventilator and to assess the patient's response to ventilatory support. One thing that needs to be done when this patient ventilator monitoring occurs is inspection of the mechanical ventilator to ensure that settings applied to the ventilator correspond to the medical staff's orders, that monitored patient values are within normal limits, that there are no leaks or obstructions in the circuit, that the circuit is correctly positioned, so there's minimal traction on the breathing tube, and that there is no presence of water in the circuit. If there is, it may need to be drained out. The patient ventilator monitoring, of course, requires assessment of the patient, and it will be important to assess the following. Vital signs: patient's heart rate, oxygen level, saturation, blood pressure, temperature will all be seen generally on a patient monitor, and it would look as the photo in the right-hand side looks. And they will also want to check The attendant will also want to check breath sounds using a stethoscope to determine whether air is entering both lungs equally or if there are gurgling sounds heard. This might indicate fluid in the lungs and the need to clean them out. Part of the patient ventilator monitoring will absolutely need to include breathing tube care. So the breathing tube is called an artificial airway, and it refers to the endotracheal tube, the tube through the mouth, or a tracheostomy tube, the tube that goes into an opening in the neck. They need to be carefully inspected. One thing that needs to be inspected is the cuff or the balloon of these tubes. They need to be inflated within the trachea to prevent leaking. They shouldn't be overinflated, as this can lead to injury to the trachea. And we have the endotracheal tube in place here. And on this one, we can see the tracheostomy tube in place here. And to inflate the cuff, you would take a syringe and inflate through this line right here. And to attach to the circuit, it would be attached here. This is the cuff inflated within the trachea, and on the tracheostomy, this is the cuff inflated within the trachea. And to inflate the cuff is this little device at the end of a small line, and you push a syringe into that to inflate and deflate the cuff. As well, in terms of breathing tube care, the security of the tape must be inspected. The endotracheal tube must be firmly attached in position at the mouth by either tape or cloth or other type of security system. The tracheostomy tube must also be firmly attached in position at the neck. And to confirm the exact position of the tube in the trachea, particularly for an endotracheal tube, reference numbers on the outside of the tube can be noted in relation to the teeth or lips. And here we can see a reference number on the right-hand side of 22 at the teeth. If that tube moves inside the trachea, up and down in the trachea, and it might be displaced, a reference point is to make sure that the reference numbers are still 22 at the teeth. So that is a good example and needs to be checked very, very routinely. So adjustments to mechanical ventilator settings. Mechanical ventilator settings are adjusted according to the patient's clinical condition, as well as by the analysis of arterial blood for the contents of oxygen and carbon dioxide. This analysis can be done invasively via a blood sample, as seen on the right, or non-invasively via probes on the finger, that's for oxygen, on the left, and via a device placed on the circuit that measures expired carbon dioxide. And those two devices don't require a blood sample. As stated previously, oxygen is required by the body as fuel for the cells, and the waste of this interaction is carbon dioxide, which must be expelled to the atmosphere. The mechanically ventilated patient's oxygen levels may be too low, requiring adjustment to increase those levels, and carbon dioxide levels may be too high and need to be reduced by other ventilator adjustments. Certain settings on the ventilator have an effect on oxygen levels, and others have an effect on carbon dioxide levels. Settings that affect oxygen, which is called oxygenation, are the FiO2 settings and the PEEP settings. If I were to increase either one, the oxygen level would rise. And settings that have an effect on carbon dioxide levels, also called ventilation, and what we're doing is adjusting the minute volume via tidal volume. Now, tidal volume isn't always directly set, in volume control it is, but it's indirectly set in pressure control by the amount of pressure set. So the tidal volume and the respiratory rate will have an effect on the carbon dioxide levels. Normal results for oxygen and carbon dioxide can be received from an invasive method or from non-invasive method, as previously described. For the blood sample invasive method, a pH will be received from this evaluation, and a lower number indicates more acid in the blood, and a higher number indicates more alkaline in the blood. The normal range is between 7.35 and 7.45. Carbon dioxide ranges between 35 and 45 millimeters of mercury. This is the partial pressure in arterial blood and often referred to as PaCO2. Increased levels require more ventilation. An increase in minute volume, so one could increase the respiratory rate or could increase the tidal volume or indirectly increase the pressure level. Oxygen ranges somewhere between 80 to 100 millimeters of mercury. Again, this is a partial pressure in arterial blood, also known as PaO2. Decreased levels require an increase in either FiO2 or PEEP. For the non-invasive method, carbon dioxide can be measured by gas analysis of the expired tidal volume. It's called capnography, and the normal is similar to the blood sample level of CO2, 35 to 45 millimeters of mercury. Some devices report it as percentage, and the normal will be between 5 and 6%. The same thing works here. Increased levels require more ventilation. Increase minute volume by either the rate or the tidal volume. The oxygen finger probe, also called oxygen saturation or a pulse oximeter, the normal ranges between 95 and 100%. Again, decreased levels require increase in the FiO2 or the PEEP. There are two case studies that we will go through that illustrate some of the points that have been discussed in this PowerPoint presentation. So case study 1. This is a 46-year-old, 65-kilo man who is suffering from COVID-19. He is making feeble efforts to breathe. His vital signs are deteriorating. The results of the arterial blood sample with the patient on an oxygen mask are as follows. The pH is 7.25, the PaCO2 is 57, the PaO2 is 71. The decision is made to place this patient on a mechanical ventilator. He is intubated, a tube is placed through his mouth to his lungs, and he is attached to the ventilator. The following settings are chosen. The mode will be volume control assist control. The tidal volume 390 milliliters, the respiratory rate 14, the peak flow 50, the PEEP of 8, and the FiO2 of 40%. To clarify what was chosen for this patient in terms of ventilator settings and to analyze the gases, so we'll go through exactly what was done for this patient. In terms of the initial assessment of his arterial blood sample, and remember this patient was on an oxygen mask, the pH shows an acidosis, normal being 7.35 to 7.45. His carbon dioxide level was 57. This is elevated and likely due to weak respirations, and the patients cannot get rid of CO2. His PaO2 was 71. It is decreased level of oxygen, normal being 80 to 100. And why were those particular ventilator settings selected? The mode volume control assist control was chosen because the patient requires full support. either volume or pressure control would have been satisfactory. In this case, volume control was chosen. Because of that, there's a tidal volume to set. 6 milliliters per kilogram was selected. The normal usually 6 to 7 mils per kilogram, but patients who have COVID-19, their lungs are easily injured with high volumes or high pressure, so 6 mils per kilo was chosen and multiplied by his weight gives us 319 milliliters. The respiratory rate was set at 14. Once this has been decided, the resultant minute volume was calculated as 5.46, which is normal for an adult. The peak flow, because we're on volume control, we have to set a peak flow, 50 liters per minute, which is normal, and it will provide a sufficient time for inspiration. And a PEEP of 8, the patient's oxygen is very low, despite being on increased FiO2. He was on a face mask, so that's required. The PEEP is going to help by holding air in the lung during exhalation, preventing collapse, and this should help to improve the oxygen levels. An FiO2 of 50 is an initial starting point. This may need to be increased or decreased and couldn't be done quickly if monitoring via a finger probe is present or by a blood result. Case study 2 involves a 62-year-old, 55-kilogram woman who has been on a ventilator since suffering serious injuries in a motor vehicle accident 1 week ago. She's on the following settings. The mode is pressure control, assist control. The pressure control level is 20 centimeters of water, and her monitored exhale tidal volume is 475 milliliters. The respiratory rate is set at 16 per minute, with a total rate of 23 per minute. The derived minute volume, therefore, is 10.9 liters per minute. The inspiratory time is 0.75 seconds, with the derived inspiratory to expiratory ratio of 1 part inhalation to 3 parts exhalation. Her PEEP is at 5 centimeters of water. Her FiO2 is set at 35%. The arterial blood gas results show a pH of 7.48, a PaCO2 of 33, a PaO2 of 89, and an oxygen saturation probe shows 96%. The patient has been steadily improving. She is awake and cooperative. Her vital signs are within normal ranges. The decision is made to try to remove her from the ventilator in a gradual fashion. How should this be carried out? Is the patient ready to be weaned from the ventilator? The answer is yes. The patient's general condition is improving. She is generating good volumes on a pressure level of 20. So the volume that she's generating is 475 milliliters. She's triggering breaths above the set rate for a total of 23. And her derived minute volume is greater than would be actually necessary at 10.9. From her blood analysis, the pH is higher than normal, showing the blood is more towards an alkaline state. The PCO2 is lower than normal at 33. This indicates the support the patient is receiving might be too high. Her derived minute volume is almost 11 liters per minute. Her normal minute volume would likely be around 5 liters per minute. The PaO2 at 89 shows good oxygen levels on a fairly low FiO2 and a minimal PEEP. Her oxygen saturation finger probe shows a good level of oxygen saturation at 96. So, how will this patient be weaned? Steps. Step 1. Switch to a partial support mode. So pressure support ventilation would be a good mode for her. She seems to be able to trigger breaths on her own. She's awake, and the following settings may be useful for her. The pressure level, one could start with the same pressure level that she was on assist control, which was 20. The exhale tidal volume needs to be monitored, and perhaps a target volume of maybe 385 milliliters, that's figuring 55 kilograms, her weight times 7 mils per kilo, could be the target. So the pressure level can be subsequently decreased to achieve this target. The expiratory sensitivity is usually set at 25%, which means that once 25% of the patient's peak flow is reached, inspiration will end. The FiO2, it would make sense to match what the patient was on. Her oxygen level was sufficient on this FiO2, and the same would be for the PEEP of 5 would be fine. The apnea alarm needs to be set now because she's on a mode that does not have a set rate. So this needs to be set, and 20 seconds is normal for an adult, and that means that if the patient stops breathing after 20 seconds, the alarm will ring. Likely there's an apnea ventilation that needs to be set. So in other words, if the apnea alarm is exceeded, the machine will switch to a ventilation mode that provides a set rate. So the pressure level of 20 with a rate of 16 would be fine for this. And of course, all the alarms have to be set according to the monitor data and settings. So that would be switching a mode and changing the mode parameters or the settings. The second thing to do would be to monitor. So the attendant needs to watch for signs of fatigue. So that would include an increased respiratory rate and a decreased exhaled tidal volume. The patient may seem agitated, the oxygen levels may drop, and the CO2 levels may rise. The patient can then be weaned, continue to be weaned, and if the patient is doing well, the pressure support level can be reduced. Sometimes it's over a few hours, sometimes it's over many hours, sometimes it's even over a day as they tolerate it. And finally, the patient can be removed from the ventilator once they tolerate low levels of pressure support, usually around 6 centimeters of water. Patient's removed, the breathing tube is removed. And this ends the presentation of basic mechanical ventilation part 2.